In this video, we'll discuss Crohn's disease. We have discussed some of its features with ulcerative colitis in our previous video. Please watch that. Now let's discuss Crohn's disease. In inflammatory bowel disease, oral tolerance is suppressed against the dietary antigen. I have discussed pathogenesis of the Crohn's disease in the other video, but briefly here, oral tolerance is suppressed against the dietary antigen due to immune dysfunction in the intestinal cell, leading to severe inflammation in ulcerative colitis and Crohn's disease. The CD4 cells in the lamina propria of the intestine secrete inflammatory cytokines. The abnormal immune response of the intestinal epithelial cells occur due to many microorganisms like Salmonella, Shigella, and other bacteria, and the substances that alter the intestinal flora, metronidazole and ciprofloxacin, may also be responsible for it, and elemental diet. Psychogenic factors may also cause Crohn's disease, and in the environmental factor, for example, smoking has a twofold increase in the Crohn's disease. In monozygotic twins, the concordance rate for Crohn's disease is 60%, and that for ulcerative colitis is 6%. So smoking causes twofold rise in Crohn's disease, and in monozygotic twins, it's 60% in Crohn's disease. Crohn's disease is a chronic granulomatous disease that, unlike ulcerative colitis, is discontinuous and transmural condition involving all the layers of the intestinal wall. Crohn's disease has non-caseating granuloma. It's an ulceroconstrictive condition that may involve any part of the GI from mouth to anus. 30 to 40% of the patients have a small bowel disease, and 90% of patients with a small bowel disease have terminal ileal disease. So it has non-caseating granulomas and an ulceroconstrictive condition from mouth to anus involving whole GIT, and the most common site is small bowel, and 90% of cases are in terminal ileum. And 45 to 50% of patients have both a small and large bowel disease. The bowel wall is thick and narrow, and 25% of the patients have colitis alone. Rectum is often spared. So summing up it, the most common site of Crohn's disease is small bowel, and 90% in the terminal ileum, and 50% patients have both a small and large bowel disease, and 25% of the patients have colitis, and rectum is often spared. The macroscopic features of the Crohn's disease. Earliest macroscopic features of the Crohn's disease are multiple aphthous ulcers separated by normal intervening mucosa. These ulcers may coalesce to form serpiginous and linear ulcers. The earliest findings are aphthous ulcers with normal intervening mucosa, and they coalesce to form serpiginous and linear ulcers. They have normal skipped area in between the abnormal areas, giving cobblestone pattern. How many patients with Crohn's disease in the colon have fistulas, fissures, and anal stenosis? 1/3 of patients, especially in the colon with Crohn's disease, have fistula, fissures, abscesses, and anal stenosis. Radiographic sign, the Istrig sign, is due to inflammation, narrowing, fibrosis, and fistula. There is bile and B12 deficiency due to malabsorption if the condition occurs in the terminal ileum, because bile and vitamin B12 are absorbed from the terminal ileum. Endoscopic feature. In endoscopy, in mild disease, there are superficial ulcers. In active disease, there are superficial ulceration, cobblestones, which are characteristic of Crohn's disease, fusing longitudinally and transversally. Pseudopolyp can also form like in ulcerative colitis. Active disease in Crohn's disease is characterized by focal inflammation and formation of fistulous tract with fibrosis and stricturing of the bowel. The bowel wall thickens and fibrosis, leading to recurrent bowel obstruction and adhesions due to inflammation. So the endoscopic features in mild disease are superficial ulcers, and in active disease there is cobblestone pattern, which is characteristic of the Crohn's disease. Polyps may also be seen. Active disease is characterized by focal inflammation and formation of fistulous tracts with fibrosis and stricture. The bowel wall thickens and fibrosis, leading to the recurrent bowel obstruction and adhesions due to inflammation. Microscopic features of the Crohn's disease: there are multiple aphthous ulcer, number 1. Number 2, crypt abscesses with aggregation of macrophages forming non-caseating granulomas, which are pathognomonic of the Crohn's disease. and are found in all the layers of the bowel wall. So the microscopic feature are number 1 aphthous ulcer, number 2 crypt abscesses, and number 3 macrophages forming non-caseating granulomas. Other submucosal or subserosal histological features which are away from the ulcerations are lymphoid aggregate, scriptaria, fissures, fistula tract, and local abscesses. And what are the other locations of non-caseating granulomas? In the intestine, they are in mesentery and peritoneum, and other than the intestine, they are in the lymph nodes, liver, and pancreas. Clinical features of the Crohn's disease. It may be acute or chronic inflammation, may be fibrostenotic that leads to obstruction, and number 2, it may form fistulous tract. So acute or chronic inflammation, fibrostenotic or fistulous. The clinical features of the Crohn's disease depend on the site of the lesion. Most common site is a small intestine. So let's discuss ileocolitis first. So 30 to 40% patients have a small bowel disease and 90% have terminal ileal disease. The lesions in the terminal ileum, they mimic acute appendicitis with pain, low-grade fever, and mass in the right lower quadrant or right iliac fossa. So in ileocolitis, 90% is in the terminal ileum, and the features mimic acute appendicitis with pain, low-grade fever, and mass in the right lower quadrant or right iliac fossa. If the fever is high, then it indicates an abscess formation. Persistent inflammation decreases the luminal diameter and distensibility that leads to fistula formation. So first there is decrease in lumen diameter and distensibility, and then fistula formation. Fibrosis, thickening, and narrowing of the GI wall causes radiologic features of string sign. Inflammation of the ileocecal region causes microperfusion and fistula formation. Fistula may communicate with the other organs, and it may be enterocutaneous fistula. A bladder fistula causes nematuria or fecaluria. A fistula in the vagina, enterovaginal fistula, causes painful vaginal discharge and dyspareunia, pain on coitus. Now, clinical features in jejunoileitis. Jejunum and early small intestine is the site where maximal food absorption occurs. So a lesion here will cause malabsorption and steatorrhea, and diarrhea is characteristic of this lesion. There may occur hypoalbuminemia, anemia, niacin deficiency, pellagra, hypocalcemia, vitamin D deficiency, vertebral fractures, and fat-soluble vitamin deficiency. So lesion in jejunum and ileum causing malabsorption is steatorrhea and deficiency of many substances with hypoalbuminemia and fractures due to the deficiency of calcium and vitamin D. Terminal ileal disease causes bile acid and B12 malabsorption, as I earlier mentioned that they are absorbed from there. B12 deficiency causes megaloblastic anemia and neurological features. So what type of neurological feature? B12 causes posterior column defect. We have a separate video on vitamin B12 deficiency. Please watch it for further details. For absorption, B12 also requires intrinsic factor from the parietal cell of the stomach. So a lesion in the stomach may also cause B12 deficiency. Now, colitis. Features in colitis: hematochezia and toxic megacolon are less common than in ulcerative colitis. Stricturing in colitis leading to intestinal obstruction, and that occur in 5 to 15% of cases. Rectovaginal fistula occur in 10% of cases, and it may fistulize to the stomach, duodenum, and small intestine. So in colitis, fistula may occur to many organs including vagina, stomach, duodenum, and in small intestine, and there may occur intestinal obstruction in 15% of cases. But hematochezia and toxic megacolon in Crohn's disease colitis are less common. Now, perianal disease clinical features are incontinence, stricture, peripheral abscesses, and anorectal fistula. The lesion in the gastroduodenal area will cause pain, vomiting, and H-pylori negative gastritis. And also I told you B12 deficiency because intrinsic factor will be deficient. Now, laboratory finding in Crohn's disease, like ulcerative colitis, there is increase in C-reactive protein, ESR, and leukocytosis. There is decreased hemoglobin, anemia, and decrease in serum albumin because the disease affects the small intestine most commonly. So what are the features of endoscopy? Endoscopy in Crohn's disease shows number 1, rectal sparing, because rectum is often spared in Crohn's disease as opposed to to ulcerative colitis. Number 2, endoscopy shows aphthous ulcers, fistulas, skip lesions. And what is the therapeutic use of endoscopy? Balloon dilatation of the stricture of less than 4 cm can be done with endoscopy, but the contraindication is acute inflammation. Balloon dilation in acute inflammation may cause perforation. Now, colonoscopy in Crohn's disease. So what colonoscopy does? It does examination and biopsy of the mass lesion, strictures, and biopsy of the terminal ileum. Number 2, balloon dilation may also be done by colonoscopy. So balloon dilation may be done by endoscopy and colonoscopy, not done in acute inflammation. Now, virus capsule endoscopy. Barium capsule endoscopy is now replaced with a camera. So this capsule endoscopy visualizes entire GIT and diagnoses the disease better than CT and MRI. So the capsule containing a camera is taken orally or ingested. Camera takes the pictures of the digestive tract while passing through the different parts of the GIT from esophagus to the anus, and finally it's expelled out. So what are the complications of this capsule endoscopy? The most common complication is capsule retention in about 1.4% of patients. And what's the contraindication of capsule endoscopy? Is suspected obstruction, stricture, or fistula. So capsule endoscopy is done with a camera in a capsule, and it visualizes entire GIT from esophagus to the anus. Finally, it's expelled out and may be retained in few cases. And the contraindication to capsule endoscopy is obstruction, stricture, or fistula. So what are the radiologic findings? Early radiologic findings are thick intestinal folds, cobblestoning, and aphthous ulceration. And in advanced disease, there occur stricture fibrosis, fistula, inflammatory mass, and abscess. Now, CT and MRI enterography done with oral and IV contrast and with enteroclysis. They identify active small disease or active small bowel inflammation. MRI shows better soft tissue contrast and it avoids radiation exposure. But CT is done easily and it's available at many places. So CT and MRI enterography are done with contrast and enteroclysis, and these identify active small bowel inflammation. MRI show better soft tissue contrast and it leads to less exposure to radiation. Now, serologic markers of the Crohn's disease. ASCA, Saccharomyces cerevisiae antibodies, are positive in 70% of cases of Crohn's disease and about 10% in ulcerative colitis, whereas ANCA, anti-neutrophil cytoplasmic antibodies, they are positive in 70% of cases of ulcerative colitis and 10% in Crohn's disease. So ASCA is more important as a serologic marker for Crohn's disease and is positive in about 70% of cases. Other tests are antibodies to E. coli protein, Pseudomonas fluorescens, and anti-flagellin antibodies. They are positive in 50% of Crohn's disease patients. So the serologic markers for the Crohn's disease are ASCA and antibodies to E. coli, Pseudomonas, and flagellin antibodies, positive in 50% patients. Patients positive for all 4 immune responses, that is ASCA and antibodies to E. coli protein, Pseudomonas, and anti-flagellin antibodies, have aggressive disease and they have early perforation. So the importance of the immune responses is that if all 4 positive, then the disease is aggressive and their chances of early perforation are more. Extra intestinal lesions of the Crohn's disease we will discuss in a separate video.